Hello, everyone, and welcome. I am Susan Winkler, Chief Executive Officer of the Reagan-Udall Foundation for the FDA. Thank you for joining us today for the Real World Accelerator to improve the standard of collection and curation of race and ethnicity data in healthcare. The Foundation, in collaboration with the FDA's Office of Minority Health and Health Equity, is pleased to host this important discussion about data and how it connects to health equity and health outcomes. I have just a few housekeeping announcements to cover. We welcome your active engagement in today's meeting. If you'd like to ask a question, please enter it into the Zoom Q&A and we will get to as many questions as time allows. We have a large number of people registered for today's event, so your microphone and camera will remain off during the workshop. The slides from today's session are already available on the Foundation's website at Reagan-Udall.org, so we invite you to look there. And then soon we will be posting the full video recording after, but obviously that will be after the meeting. So after we've completed the session, we will be posting the recording on our website. Then I'll just remind you of where we are in the RAISE journey. For some of you, this is the first conversation. For others of you, this is the last of our series of 11 virtual conversations to explore the challenges and opportunities to improve the collection and transfer of race and ethnicity data in healthcare. We are excited to share what we've learned. And if you're curious about our prior discussions, the workshop summaries are also available on our website. So let's talk about our agenda. The main portion of today's workshop is a presentation from RAISE co-investigator Dr. Alicia Clary on the barrier, facilitator, solution triads that have emerged from our virtual conversations. Then to help us explore those triads, we will have two in-depth panel discussions. The first explores considerations of the RAISE roadmap implementation, and the second panel will discuss the potential impact of the roadmap. And we'll wrap up with closing remarks from RAISE principal investigator, Dr. Carla Rodriguez-Watson. Now, I mentioned that we have had just a stellar partner in all of this work, and that is FDA's Office of Minority Health and Health Equity. So to get us started today, I'm going to turn over to Rear Admiral Richarde Arrojo for opening remarks. Thank you so much for joining us today.
Thank you so much, Susan, and good afternoon, everyone. It's truly a pleasure to be with you today to open our discussion and, of course, unveil the new RAISE recommendations for a multidimensional tool to help prioritize strategies to improve the collection and curation of race and ethnicity data based on the barriers and solutions discussed in previous RAISE community meetings. I want to thank all of those who have participated in the RAISE workshops for their contributions to the vital discussions designed to help improve data collection in our ongoing efforts to develop safe and effective medical products and deliver effective healthcare for all patients. I think we can all acknowledge how important accurate and reliable data is to being able to meet these goals. The FDA Office of Minority Health and Health Equity has long worked and remains committed to advancing health equity, including efforts to advance equity of data. Incomplete and inconsistent capture of information about race and ethnicity in real-world data limits a full understanding of the distribution, safety, and effectiveness of FDA-regulated products, which impacts the health of the public. For that reason, the FDA's Office of Minority Health and Health Equity funded RAISE, a collaborative project between the Reagan-Udall Foundation and our office. The project was funded through our Enhanced Equity Initiative, which includes continuous efforts to advance equity of data. This data is important to help identify patterns and trends in medical product usage, healthcare, and downstream health outcomes across different populations in the United States to reduce health disparities. Over the past few months, RAISE has hosted 11 virtual community workshops covering topics such as technical challenges in the transfer of information, misclassification and measurement bias, and addressing the missingness of race and ethnicity data in healthcare settings, to name just a few. Over that time, we have built a RAISE community of more than 500 people representing government, ethics and law, healthcare, life sciences, technology, and research, among many others. The virtual workshops facilitated a series of conversations exploring challenges and opportunities and encourage active conversation and information sharing among the RAISE community. The information gained from RAISE is encouraging, and we hope to continue to engage with all stakeholders to reach the important goal of improving the collection and curation of race and ethnicity data. And with that, I want to thank each of you again for being a part of this effort and for joining today's workshop. I look forward to the discussion, and I will turn things back over to Susan.
Great. Thank you so much, Rear Admiral Araujo. As you recapped that, I was thinking back to the many rich conversations we've had, and we so appreciate your leadership on this project and look forward to hearing kind of everything pulled together. So to hear about everything being pulled together, it's time to turn to Dr. Alicia Clary to discuss the RAISE roadmap. Dr. Clary is co-investigator of the RAISE project, as well as the founder and president of Evidence to Practice. Alicia, take the stage.
Thanks so much, Susan, and good afternoon, everyone. My name is Alicia Clary, and I am a co-investigator on RAISE. Next slide, please. So I'd like to begin by acknowledging contributions from RAISE speakers, panelists, and participants, as well as the RAISE team. I have the privilege of presenting this work to you today, but this definitely was a collaborative effort. And anything that resonates with you or sounds particularly smart, please do attribute to yourselves and the RAISE community. Any errors, please do attribute to me. Next slide, please. As we've been discussing over the past 11 workshops, the incomplete and inconsistent collection of race and ethnicity data within healthcare data sets limits the inclusive medical product development and safety assessment. And the barriers to complete and accurate capture of these data lie along the data continuum. Consequently, there's no single stakeholder who is responsible for collecting or managing these data. In RAISE, we sought to understand the barriers from a multi-stakeholder perspective and to hone in on a set of actionable next steps towards solution. Next slide, please. So we used a primarily qualitative approach to developing the roadmap of solutions. Over the series of 11 weeks, we've identified the barriers in our RAISE meetings, and solutions were similarly identified from RAISE meetings as well as the literature. During our last workshop, we had an opportunity to present the list of barriers and solutions, asking the community to help us prioritize the barriers that are important to address and solutions that are implementable. Today, we'll discuss the barriers and solutions that the RAISE community helped us to prioritize. And shortly after this meeting, we'll reach out to all of you to ask you to cast your vote about your perspective of the overall resource burden associated with implementing the solutions, as well as your perspective of the benefits of implementing the solutions towards more complete and accurate collection and management of these data. Next slide, please. Just so we're all speaking the same language here, we did want to start with some of the definitions that we've been using to guide this work, where the barrier has been defined as the obstacle that prevents the collection and management of these data. Facilitators are the set of activities that can help us to reach our goal, and the solutions are the goals that we're trying to accomplish. Next slide, please. And now the prioritized list of barriers, solutions, and facilitators, as well as recommendations towards actionable next steps. It will come as no surprise to you all that most of the prioritized barriers and solutions lied at opportunities to improve data collection. The RAISE community recognized that the data must be available in order to be meaningfully curated, shared, and integrated. I'll also note that several of the solutions that we'll discuss today are currently being implemented in healthcare settings. Next slide, please. It will come as no surprise that funding and incentives were highly prioritized by the RAISE community. Incentives and measures point the healthcare community towards priorities for improving patient care and outcomes. The RAISE community suggests that one facilitator towards realigning funding and incentives is to incentivize health equity. Although important to the healthcare community, we heard that historically funders, accreditors, and others have added health equity as a goal after measure design, for example, instead of prioritizing health equity as a goal during measure design. Specific steps towards incentivizing improvements in health equity include defining the purpose of updating the payment model or measure such that the definition specifies where the purpose lies on the continuum between collecting better health equity data and improving health equity outcomes. Convening work groups to understand the availability and the specific opportunities to create or update measures, and actually updating or developing measures and monitoring their use over time. Next slide, please. Next, the community recognized that there continues to be a lack of transparency regarding how the data may be used. We heard that this may be particularly salient for populations who may be at increased risk for bias or harm when reporting these data. Therefore, it's important to begin with acknowledging these potential risks. We frequently heard that in order to inform people about why these data are being collected and how it may be used, we must first understand that ourselves. There's an opportunity to be specific and intentional about why we are collecting these data, how they may be used, and who may have access to them for specific purposes. It's only after understanding these things that we can develop messaging that can then be piloted in the community and updated based on patient and member feedback. Next slide, please. One of the reoccurring themes in RAISE has been tension. More specifically, we heard that healthcare organizations are really grappling with right-sizing the number of race and ethnicity options that they provide. We heard that when there is too much aggregation, people don't see themselves in the options. Conversely, we heard that no one is going to search through 600 options to find the categories that represent them, and that individual organizations are managed preferred by patients and members. Using the results of that research to facilitate the development of a menu of options from which organizations can select, developing a tool to help organizations systematically and efficiently prioritize the options based on their community needs, ensuring that each option is respectful of people and doesn't contain historical language that is harmful, and reflective of the local community such that people see themselves in the data, but it's complementary enough that there aren't 600 options and the data suffer from death by 1,000 clicks. And finally, there's an opportunity to pilot these options in the community and simultaneously test approaches to aggregation during those pilots. Next slide, please. Once armed with the most representative options from their community, data collectors need training about best practices towards collecting these data. Specific steps include desk research and primary data collection about existing training and training needs, including understanding the barriers and facilitators of consistent collection of these data, understanding how existing approaches can be improved to better align with the collection of other data, and also understanding where data collection might fit best into the workflow. Following this research, there's an opportunity to design or update training tailored for different roles and data collection at different points, evaluating training effectiveness, and of course, to continue to update trainings based on evaluation findings. Next slide, please. After we've developed language to explain why these data may be collected, there's an opportunity to refine the response options such that they reflect the community, can be aggregated across communities, and developing training on collection of these data. After we've developed language to explain why these data may be collected and right-size their response options, now we need to develop tools to facilitate the collection of these data. Next steps include collecting data about existing tools, adopting or developing new tools, which can be made available in different mediums and translated into different languages, and testing and validating the tools, training data collectors to use the tools, and monitoring use of them. Next slide, please. And finally, you can't have a conversation about real-world data without discussing data standards. There are several different organizations and agencies who own data standards, but the RAISE community has identified that there is always room for improvement in terms of adoption and innovation. Of note, we heard from OMB that there is work underway to update the existing OMB race and ethnicity categories and guidance, which leverage several of our proposed next steps, including holding listening sessions that inform the development and refinement of the proposed options. And the RAISE community identified that there will still be a need to map between different standards and also to map between the previous standard and updated standards within OMB and between OMB and others. The RAISE community also acknowledged that when creating or updating standards for race and ethnicity data, it remains important to establish a clear goal of wanting to improve the collection of these data to inform existing standards and protocols. Each of these solutions and next steps suggests that there is a need to fund these efforts, understand why these data are being collected and how they may be used, identify and engage the relevant stakeholders, align on specific objectives for work groups and convenings, and also identify a mechanism to disseminate and increase uptake and adoption of new tools and resources. And finally, one of the primary barriers prioritized by the RAISE community was the lack of relationship between people and the systems collecting these data. This extends beyond the healthcare system and includes other systems which might be leveraged to collect these data. A RAISE participant said, "This work begins with a framework of trust that guarantees that there aren't unintended consequences, harm, or bias. Therefore, each solution and next step incorporates patients and members as key stakeholders for convenings and work groups. The problem really needs to be taken to the community instead of expecting the community to come to the healthcare system, and that the results should be disseminated to the community." A final quote from a RAISE participant: "We need to enable the community to feel seen, be heard, and be counted. This will generate enthusiasm within the community and lead to increase and deeper engagement. Use data that can be shared back with the community so that the community experiences a return of value." Next slide, please. And back to you, Susan.
Thank you so much, Alicia, for walking us through. You've somehow taken 11 plus hours of content and helped weave that into a roadmap that is particularly helpful. So we so appreciate it. As we've heard through much of the workshop series, trust is critical for this work, and there's a lot to unpack in what you just presented. So I want to turn us to our first conversation about the considerations of implementing the work that you just presented. To moderate our first panel, I invite Dr. Carla Rodriguez-Watson, who is Principal Investigator for RAISE, to step to the stage. And then joining her will be Dr. Alan Shao, who's Chief Information Officer for the Yale School of Medicine and Yale New Haven Health, Dr. Rachel Hendricks-Stirrup, Director of Real World Evidence at Duke Margolis, and Linnell James, Business Lead for Health Information Exchange and Innovation at the Blue Cross and Blue Shield Association. So Carla, are you and your discussants ready?
I believe we are.
2/3. Yep. All right, great. I'm going to turn it over to you.
Great. Thank you so much, Susan. And thank you, everybody. Thank you again, Rachel, Linnell, and Alan, for joining this conversation today. So, Alan, as a pediatrician and the Chief Health Information Officer at a major healthcare delivery system, I'm going to start with you and ask you about awareness. In order for some of these solutions to be implemented, hospitals have to understand that they have a problem that needs fixing. Do you think there is awareness? And if not, how do we raise awareness? What are you doing at Yale?
Yeah, those are all great questions, Carla. Definitely, I think worthy of a bit of reflection on. I think the truth is there is some awareness, but probably not enough, and it's still growing awareness. I think, you know, it also varies a lot even by the hospital and the health system, how much awareness there is. I think I can imagine where hospitals that are involved heavily in research historically, or maybe in a population health programs, where they're looking at disparities of care and looking at things like race and ethnicity, have a little bit more experience and understand the importance of collecting that data. And other hospitals that perhaps aren't involved in research and may not be looking at population health that way may have a little bit less experience, and maybe as we have been at some of our community hospitals, kind of collecting that information but not really scrutinizing it or really looking at how accurate it is. And I think what we're realizing now is that there's a lot of work to be done to raise awareness, I think, nationally across all of our hospitals and health systems, and even locally, where we feel like we always thought we'd done a pretty good job of collecting that data, to kind of reevaluate and how accurate is it? Are we including all the information that the choices that our patients need and expect and want, and then are we actually then doing a good job of taking that information and using it? So I think there's a lot of work that needs to be done, and I think to your point, the other question is how do you raise that awareness? I think a lot of that is just continued great work that this group is doing. For instance, I think these workshops have been tremendous. I personally have learned so much from them myself, and I really feel like so many of my colleagues in other hospitals would really benefit from the content and the information that this workshop series has been sharing and publicizing. So I think more of that. I think really appreciate the FDA and Reagan-Udall kind of taking that on and working to publicize this information and gather the information from so many experts. I think other ways that the kind of the I think not just the education, but the other ways that kind of increase the prioritization of how important, because that's part of the problem, is that there's so many high priority things for hospitals, health systems to focus on these days, and it's so hard for them. It's like it's just like like everything seems like it's on fire, right? You're worried about financial pressures, you're worried about this, you're worried about that. Certainly worried about disparities of care, but what do you focus on? And so I think steps where like the Joint Commission is having new requirements. Revised requirements to reduce healthcare disparities is going to go a long way to raising awareness and really helping hospitals to identify that, hey, we need to actually pay attention to this even more than we have been, and really make sure that the information is important. And for ourselves, locally, we've had to do a lot of soul searching and look at the accuracy of our data. We've actually historically done a very good job of collecting race and ethnicity data. 97, 98%, we feel like we have that information for our patients. But now I think we're looking back and be like, do we have all the categories we really need? Is it really accurate? Is it, was it really the patient's self-reported information, or did someone look at a patient and be like, oh, and assume that patient was a certain race and ethnicity, and then record that into the EHR? And then even concepts that I've learned, from this workshop series, that race and ethnicity actually can be an evolving, identity, I guess, of a patient that actually may change over time. That is definitely not something that I think is very well, people in hospitals are very well aware of. And so I think publicizing that information is also, very important as well. And so, you asked what we're doing at Yale, besides looking at our information more specifically. I think another thing that hospitals can do, and we've taken steps in the past couple of years, is also to appoint leaders who really think about this in depth. And this includes physicians. So we have a terrific, a couple of, I think, of leaders at Yale, and, Marcela Nunez-Smith, and then we also appointed a medical director in Lou Hart, to really look at how we collect race and ethnicity data. Are we using it the right way? Do we have the right categories? And things, and how do we leverage the electronic health record to record the information in an accurate way and make it available? How do we make it available so patients can self-report, for instance, as well? And so I think it's a combination of raising awareness, the great work this group is doing, and I think hospitals also responding to things like the Joint Commission new requirements with, I think, more focused resources and appointed leadership to really tackle some of these challenging things.
Alan, thank you for that tour de force of like underscoring all the great things happening in Yale, but with your leadership and curiosity, really, like, I think what you conveyed to this audience is digging in more. You had said, even with 98% reported, you're questioning now, like, how did we actually capture it? Did we really ask? Did we just observe? And I think your point about, kind of observing, maybe it's the big academic centers or the ones that are already engaged in research that are doing pretty well. And that maybe the ones that are just really focused on clinical care that need to have more awareness, more information about the incentives, tools, requirements that are out there. And I think that's going to be even more important, right? As the FDA and as we think about medical product development and going to more inclusive trials, is looking at decentralized trials to really make it more accessible to patients from where they are and where they live. I wonder, does anybody else on the panel have anything that they want to add to that? Dr. Hendricks-Stirrup, any thoughts? I don't want to put anybody on the spot, but if anybody wants to chime in, please do.
No, thank you. I just want to echo Alan's comment. I just want to thank you all and the RAISE team for, highlighting this discussion because, I come to this discussion with a perspective of based on work that I've done as a leader within the National Alliance Against Disparities in Patient Health. And, we've done a lot of work with communities that may or may not be self-aware of their race and the role and or ethnicity and the role that plays in the context of them accessing and receiving or even responding to healthcare or treatment regimens. And so I think, again, drawing on the perspective that I bring to this, it's so vitally important to understand how persons with lived experience are presenting themselves to the healthcare system and how they are perceiving their race, ethnicity, and culture within that context, within the full scope of possibilities of care options that are even available to them. And that includes access to clinical trials and their ability to receive or access novel therapies that are only available through clinical trials within their health systems. So I just want to emphasize that point and build on Alan's points as well from that perspective.
Thank you, Rachel. And so now I'd like to turn to Linnell and ask you, Mr. James, a similar question. There is a lot of misconception about if and when payers can ask for race and ethnicity information. As we learned in Workshop 1 from the National Academy for State Health Policy and Quality, there are only actually 5 states where collecting race and ethnicity is prohibited, and that is only at enrollment. We heard that echoed by your colleague at Blue Cross Blue Shield in Massachusetts in Workshop 1, and truly drove home that the system needs to set up policy that is on the needs to set policy to put in place the organizational will and resources to make better collection of race and ethnicity a reality. I believe her words were, the leadership at Blue Cross Blue Shield Massachusetts put equity on the same footing as quality and cost. For other insurers who haven't made that leap yet, what is the best way to get in front of their leadership to make the pitch that capturing data to improve health equity isn't just the right thing to do, but is good for business? And to share with them information on incentives offered by NCQA or value-based payment models to improve capture of race and ethnicity.
Well, thank you for that easy question, Carla. How hard could it be? Well, a great question. For some of you may know, my background includes being the payer advisor to the HL7 Gravity Project, which is focused on social determinants of health. And as part of that, I've been working closely with NCQA on the race and ethnicity parts of that. I think the good news is the leverage to get in front of payers is partly being provided not only from NCQA as part of their HEDIS, saying for selected measures you need to collect race and ethnicity, but more importantly, many of you know that the Office of the National Coordinator under ONC is responsible for providing certifications for what EMRs can do, and the payers get a lot of information from the EMRs. Well, one of the initiatives that the ONC put out as a request for information to the whole industry, which was clearly targeted for the EMR vendors, was to look at race and ethnicity and how that's collected and a requirement for them to collect it, and along with NCQA looking at payers and saying, for health equity accreditation and for your HEDIS, you need to do race and ethnicity. And last but not least, CMS came out with a request for information aligned to the OMB work on race and ethnicity, again, signaling that for payers and providers, that CMS has an expectation that race and ethnicity will be part of their health equity play. So it's not so much what's the value proposition, it's making sure that inventory of additional activities that the payers and providers as stakeholders are paying attention to, realize not everybody follows all the things that some of us pay close attention to policy, close attention to standards. So the inventory is there. It'll be part of what RAISE can make available to inventory and showcase the things that payers and providers and their vendors already are on notice that it's coming. Sometimes it's important to point that out to leaders who are so busy with the day-to-day of keeping the trains running on time and meeting current obligations. Sometimes it's just, I think, incumbent on some of us on this call to remind them to look to the future and the expectations of NCQA, the feds, health equity. And let me take a quick side trip. When we talk about health equity, one of the things that's going on is that the Argonauts, for example, which is the Argonauts are where the EMR vendors get together and talk together as a group in terms of what are the key initiatives that they're going to be looking at, much like with the Gravity Project, payers, providers are looking at health equity. Well, guess what? All of those groups are talking about race and ethnicity collection, SDOH collection. So the question is, are the payers that you on this call that may be talking to, you need to realize it's not, there's a subset of the payers that are active in these standards bodies that actually understand what's going on. Well, there's 2,000 payers in the United States, and there's maybe 30 that are actively involved with HL7. So many of the payer leaders, again, the Blues and Cigna and Humana and United, we're all there, but the local payer may not be aware of it. So part of the challenge is making sure you're aware, people on this call, of that inventory of signals that the feds are sending and the industry is sending, and make sure that's part of your toolkit. So it's clear that it's not you for your local health equity initiative, but it's you being aware and enlightening them that this is already on the radar of CDC, CMS, the Office of the National Coordinator, NCQA. Some of us who bathe in this assume everybody knows. There's too many times I go to industry events where people afterwards come up and go, oh, I didn't know that was going on. And I'm like, oh, that was published 3 weeks ago or 3 months ago. Not everybody's pacing with this. So part of your toolkit when you're working with executives is to make sure you're familiar with some of those initiatives so that you can equate that to your current conversation. Because again, realize we all have silos. There's probably someone in a large payer organization who's paying attention to the policy who may not have shared that information with the health equity champion. and the IT people may know some of it, but may not have connected all the dots. So realize it's okay, and you should be making sure the inventory of knowledge about what the feds and the policies are doing need to be shared with some of the line executives you may be working with. Hopefully that helps with your question, Carla.
That's great, Liddell. So the age-old problem of like everybody's working on different parts of that elephant, and we all need to pin the tail on the elephant and everybody get into the pool, it sounds like. Again, an issue of maybe a lot of movement and momentum amongst the big payers, but an opportunity to share information with more localized and specialized payer groups. And we'll, of course, look to you, Liddell, to help share those resources with us vis-a-vis our RAISE summaries and putting those on our website. Does anybody want to add to anything that Liddell presented or discussed?
Yeah, Linnell,
Rachel.
Yeah, thank you. I appreciate your emphasis on making sure and taking the time to help make sure that some of our more local stakeholders are informed. I think many times, if not all the time, a lot of us who are working on these things at a high level or on a more national scale, we think everyone's on board and we think everyone knows, and we think that as soon as we disseminate it, publish it, or present it somewhere, that it's out there and that everyone knows about it. And even if people know about it, it doesn't necessarily mean that they appreciate it at the level of implementing what you've disseminated or even sharing further what you've disseminated. So again, appreciating that local context is I think, and many people that I work with at NADPH think is incredibly important, because that is exactly where we're going to see the most change. So I just wanted to say thank you for that comment.
Thank you.
Well, Rachel, that's a great point, and I wanted to actually pull that thread a little bit more with you. I think throughout the RAISE workshops, we've talked a lot about the need for racial category standards that are safe, contextually relevant, interoperable, and the need for people with lived experiences of inequity to be at the table to inform relevance of those standards, but also of the shared goals and outcomes with health equity. And Linnell had mentioned that all the big players are at this table. How do we get community at that table? That's something vitally important that we've talked about, is being able to get community there with bidirectional feedback to address some of those tensions that we heard about, like as Alicia presented, the simultaneously too few and too many racial categories that are presented. We heard an example from Pyxis in workshop 4 about how they engaged with the Arab Community Center for Economic and Social Services in Dearborn, Michigan, to develop a Middle Eastern North American, or MENA category. That was actually included in a federally funded All of Us research program. And now we see it being proposed as a new racial category for the Office of Management and Budget Statistical Policy Directive 15. This engagement, that engagement between Pyxis and Access, engendered trust and led to increased enrollment in the All of Us program among the Arab community, largely through social media endorsement by Access. The work of your organization, the National Alliance Against Disparities in Patient Health, and others, has also demonstrated the value of engaging people with lived experiences in equity. And if we could show that slide on the positive effects of PWLEI inclusion. Thank you. So, Rachel, can you talk about this work and what are some practical first steps for systems that are struggling with how to better capture race and ethnicity to engage with communities? Give us some practical tips and describe what good looks like.
Absolutely. So one thing I want to highlight from this work that we did with our communities is that we conducted a survey in partnership with the Michigan and Illinois Public Health Institutes. We conducted a survey of projects conducted by community data coalitions and leaders to understand exactly the extent to which they included persons with lived experience and inequity in their data lifecycle or data practices, and exactly what can we glean from that data to observe any outcomes that that arose from that effort, outcomes that are equity focused, of course, so that way we can understand any differences between outcomes that we are able to observe and capture based on, projects including persons with lived experience and inequities versus those that do not. I'll highlight some of the findings here that you see on the slide and walk you all through that. But first, we asked these survey respondents how, or at least to what extent, did you involve persons with lived experience and inequity in the data sharing life cycle? So looking at step one, planning, all the way to the last step, which is disseminating. So we did find that many projects did not involve, or to a very low extent, involved persons with lived experience and inequity in this process across this data life cycle. So looking at planning, collecting, accessing, analyzing, interpreting, recommending, reporting, and lastly, disseminating data. Large amount of the time, those persons with lived experience in their communities were either not involved or had very low involvement. And that's especially prevalent in the data collection, access, and analysis portions of the data lifecycle. So we said, okay, taking that into consideration, what are some outcomes that we can observe in our data to see, again, if there are any differences that arose as far as equitable data practices? So we saw that looking at three particular equitable data practices, the first being assessing risks associated with data sharing, the second, including community level data, and the third, addressing data biases. We saw that compared to those who did not include persons with lived experience and inequity, those individuals, or those projects rather, out of a total of 60, 35% were able to assess risks of data sharing versus 74% of projects that were able to, upon including persons with lived experience and inequity. 48% we saw with regard to including community level data, but thinking about, again, that local context as a function of community level data. 68% of projects that included persons with lived experience were able to accomplish this compared to 48% of those that did not. With respect to, and very importantly, addressing data biases, those that included, or projects that included persons with lived experience, they were able to address data biases to a greater extent, 74% compared to only 34% among projects that did not include persons with lived experience and inequity. So this is just, a nice overview or a sort of quantitative finding that you all can take with you or take back to your work today to ask yourselves, what is, the business case? What is the moral imperative around including persons with lived experiences, and how does that, or how could that impact our own equitable data practices? Well, that's what you see here. And splicing that out again across the data sharing life cycle allows us to further visualize this to understand where exactly we can engage persons with lived experience. Taking all of that into consideration as we think about race and ethnicity data, and the example you shared, Carla, with the MENA community. That's been a longstanding issue for a very long time, decades, in fact, where even within that MENA category, there's so much nuance, so much cultural diversity, even within that community, such that many individuals who identify with the North African community, they have very different cultures, health practices than those of the Middle Eastern community. So thinking again at this community as not a monolith, but rather a group of individuals that have come together to share with everyone that we feel that we are distinct we feel that as a group, we have very different ancestry, genetic ancestry and cultural practices that have implications around our health outcomes and our ability to access resources within the community that we feel are important. And so therefore, using this as an example, we do the work of taking the time to bring our whole selves, not just as researchers or as scientists, but bringing our whole selves as individuals, as persons who also have experiences in inequity, bringing our whole selves to the table to have a genuine, transparent, and very open and frank conversation with them about these things, and not feeling not feeling inferior to them and allowing them to not feel inferior to us. That's where the authenticity lies, and where you can start building trust, and therefore where you can start realizing more equity in your data practices as a result. So that's something that, again, we've done in the past, that we continue to do in our work, and something that we encourage others to do as well, especially as we think about race and ethnicity in some cases as a monolith, and less so in other cases where it's necessary to observe and advance better health outcomes.
Yeah, thanks, Rachel. I think that's really important. And I think the results are striking that you presented. I think everybody has that feeling like they want to bring community at the table, but people may feel a little bit stuck. Like, what's one concrete step, especially for some of these big engines that Linnell and Alan talked about that are all already kind of moving? How can we engage patients and communities in the table in some of this co-creating data governance and design of what race and ethnicity initiatives look like, especially for their data?
Thank you, Carla. Yeah, so you hit the nail on the head. As we sort of roadshowed these findings at various health equity conferences and convenings, we polled the audience members to ask them, what are your opinions around, whether or not engaging persons with lived experience in inequity is easy? Surprisingly, or rather, I should say unsurprisingly, more than 80% said it's not easy. I mean, and this was consistent with every audience. It's not easy. It does require a lot of labor, labor of love, labor in general, and a lot of work and time and effort. And sometimes people have the time to do that based on whatever their timelines are or budgets might be. Sometimes they don't. So again, making time to spend time with communities is extremely important and also difficult. And then also overcoming our own personal biases about communities as we attempt to engage them, overcoming our own reclusivity around bringing our whole selves to the table when we have these conversations. I think it all starts there. And also teaching the next generation on strategies to do that. Teaching them this as early as possible in their careers is incredibly important. So it's not just about developing best practices and methods around doing this, but it's also making sure that that we're giving ourselves permission to bring our whole selves into these situations and scenarios and conversations. If we are truly serious about building trust with communities so that they also feel that they can bring their whole selves to whatever initiative we're asking them to be a part of.
Right. And we heard some of those, some ways to facilitate that. I'm thinking of Institute for eHealth Equity and the work that they've done within community, because they are community, particularly from the ministry perspective, and building that consistent bridge for community being engaged, as well as, some of the technologies that we've heard about through here to help on the payer side or whoever, like, really engage their clients to manage and to drive their healthcare. Linnell, you have your hand up. Jump in, please.
Yeah, I wanted to double down on the kind of some of the other ways you get at community too. In fact, you mentioned the Institute for Health Equity. I'm an advisor to them part-time too. And one of the things we discovered in working with the community engagement from a faith-based perspective, that there are some untapped resources. And I put into the chat the CMS, one of their divisions, had a national cardiovascular health program that none of us knew about. 275 million for a 5-year program. Everybody don't get excited. It closed in April, so that one's missed, but it was focused on the state. So it was 51 awards at the state level. But here's why I wanted to bring that up. Silas with Institute for EF Equity just happened to be invited to a meeting with the state of Georgia with the church, with the faith-based institutions, and then they realized there was an opportunity to engage with technology in the community. And next thing you know, as part of Georgia's submission, they included a faith-based piece and 6-figure funding to go out in the community and gather the community and make sure they were ready as a group to work as part of this particular grant. And then once we found that one, we looked around and found $105 million in a different organization that said, we want you to work with community health hubs. And we're like, okay, where do you find the community health hubs? The reason I'm bringing those two examples out, where there's multi-million dollars of initiatives that actually include an expectation of a community component and provide funding. The issue is those things are available. We found them in Chicago, multi-million-dollar grant that went to the city and the state, went from the city and the state to some safety net hospitals in a coalition. This is a case where they bid over a year ago. I think it was $50 million. Those of us in Chicago are like, well, yeah, but are they going to have the budget? Are they going to have the money? Call back to talk to the chief medical officer literally 2 weeks ago, and he goes, no, we didn't get 50 more million. We got 90 million. I was like, what? It went up. So I'm telling you those stories for this group to realize in your city, state, region, there is funding, whether it's federal, whether it's state, whether it's Robert Wood Johnson, whether it's local, and part of that community engagement is not to ask community to do this on a shoestring. No, that's not, there's serious funding out here, and there's opportunities for funded engagement where you can put the right kind of staff to work with it, and funding so you can work with the local area agency aging or work with a federally qualified health center. Those people that are used to getting funding need to know you need to open your lens to look at health equity, look at collecting race and ethnicity data, and asking for funds to engage the community substantively, because the community is going to need some experts, and there are experts. And the issue is there's experts, there's community, there's funding. People need to be much more aggressive at seeking those funds instead of doing it the old-fashioned way, which is let's beg, borrow, ask somebody. To really make the impact we need to properly fund this work. And I'm telling you, I have just accidentally discovered in the last 90 days, and if you could hear it in my voice, I'm somewhat frustrated because I'm like, we're struggling to do this work, but there's actually money that wants to do it, and we're just not doing effective matchmaking. And I'm really hopeful that some of the Reagan-Udall work as we go into the next phases will be providing better knowledge and tooling to help match people that want to go into the community with people who have money that want to help the community, but they're not sure how to do it. There can be a real value in just connecting people and informing people, because some people, again, don't think outside of the box or don't realize the funds somewhere I didn't expect it to be. I'm trying to tell everybody on this call, there is money. You have to look places you're not familiar with, but they're eager to help you. They just don't know you're there, and vice versa.
Yeah, well, we're happy to be a matchmaker. I think you put a good next part of the next role of the raise is matchmaker 101. So that's great. And while I have you, Linnell, there was a question in the chat about whether you could add or clarify the HEDIS measures that are related to race and ethnicity. I don't know if you can put some links in the chat, or if you want to speak a little generally
I can
about
tell
that.
you just a little bit, because I remember the first five, I think a year and a half ago, there were only 5 measures, and one of them was diabetes and hypertension. So if you were doing, for your HEDIS score, you needed to show improvement in hypertension. It used to be just show me the before and after. And what they said is, no. It's before and after, and I want to know the race and ethnicity of the people you're working with so we can better align that. And as you mentioned in the very beginning, there are just a few states that prohibit it, but that's prohibiting it at registration. If I'm doing it for care coordination, if I'm doing it for quality measures, there's a new thing. And again, I don't know the states off the top of my hand, but there are several states where if you are a payer and you collect race and ethnicity, you are obligated to report it to the Department of Public Health, or there's a penalty. Well, guess what? Didn't tell that those rules, as I've looked at a few of them, they don't tell you what's the penalty, they don't tell you how to send it to the state, and they don't tell you when to send it to the state. So, when in doubt, payers tend to be conservative. You haven't told me when, how, therefore I'll just not collect it, because if I don't collect it, you can't get mad at me. That's really the wrong answer, and I'm pretty confident most payers didn't react to that by pulling back. But yeah, that's a disincentive for moving forward. So I will find the NCQA link and to get that to you, because that was a couple of years ago, and now I believe it's at least 10 or more measures. So they're gradually making it more clear. And then many of you may know JACO, Joint Commission, has required the providers to do a better job of collecting. Now, again, collecting doesn't mean they're doing it at the right granularity level. Collecting it doesn't mean they know how to exchange it. And I had put into the larger chat earlier a blog post that NCQA wrote with assistance from some payers and some standards experts to just help bridge the gap that people don't understand. A lot of the standards, the problem is there's more than one, but there are only a few, and people aren't even using the few that we have. So part of the challenge for us in the industry and RAISE is to make sure people know there are standards, you should use them. And oh, by the way, if you haven't heard, please get your comments in and work with the Office of Management and Budget, the Chief Statistician, because in 2024, they're going to be trying to improve and fix the race and ethnicity granularity. All of us need to make sure they hear loud and clear, yeah, 900 codes is too much, but you ought to have a nice minimum disaggregated race set that does include better information on Asians than the 6 they have, or Hispanics when it has 6, but there's actually 13. We need to, and maybe 6 was good, but yeah, it hasn't been looked at for years, and they didn't do anything with Black or white, and that makes, challenges. So here's the industry's opportunity to make sure we have a good working set of disaggregated data and make it the floor instead of what it is now. Oh, OMB 5 and 2, are you Black and white? No. Let's break it down a little more as a minimum so that we can collect better data, we can manage it better, we can figure out what things we want to do to improve health equity. Comes with information. Knowledge is power.
Yeah.
Right.
Oh, sorry.
Please,
I just
go
wanna,
ahead, Rachel.
if we have time, I just want to also add that it's important to also focus on some of the infrastructure level limitations around race and ethnicity data collection. So thinking about electronic health records, for example, that might have default mechanisms for collecting race and ethnicity data. We have to remember that just because race and ethnicity data is documented within the system, that doesn't necessarily mean that it has been reported to the system or collected by those entering it into the system. In many cases, the systems default to white males. I even saw this with my own electronic health record because simply the healthcare provider just did not care, or for whatever reason, didn't ask for race and ethnicity data. And so the system just defaulted to something because it was probably a mandatory field and they needed to move forward with their day and workflow. So everyone was okay with that at the end. But then when that happens, I've heard stories where healthcare providers have had to migrate their existing systems over to new ones, and they encounter an entire mess data, especially regarding race and ethnicity, because it's not, for one, it's just not accurate. Even the treatments or treatment regimens that they capture in the system are not accurate. That's one infrastructure level issue that we need to pay close attention to, especially in situations where, you know, people are operating fast on the day-to-day, just trying to deliver their services and care according to their SOPs or within the timeframes that they have and the pressures that they encounter throughout the day. That's one thing to think about. And then also, as we consider race and ethnicity as a function of health outcomes, we have to think about whether or not it's appropriate to consider race and ethnicity alone. Are there other proxy indicators that might have or weigh on our ability to observe or not observe expected treatment outcomes, simply because wherever that person is located geographically, that might have something to do with the amount of stress that they encounter or lifestyle habits that interact with our ability to predict treatment outcomes or steer those individuals to better treatment. So I just wanted to focus on some of these more infrastructure and system level considerations that we must talk about if we're going to consider race and ethnicity within the scope of clinical trials and community level outreach to engage folks in clinical trials.
Thanks, Rachel, for raising those really important points and considerations, particularly regarding infrastructure that some of us might not even know are going on, but I bet Alan does. So Alan, I'm going to leave you with the last word on this. So we've heard a lot here today, and I want to ask your opinion on anything, particularly, you know, what got raised a lot are these standards. And back to that question, simultaneously, too few and too many categories. What are you all at Yale doing with regard to this issue, and anything else you want to echo regarding migration of data and how you might leverage current technologies that help us connect the dots across patients, like tokenization, for example, that helps us merge and follow patients long-term without compromising their identifiable private information. But any last thoughts?
Yeah, thanks, Carla. I think, and maybe I'll put a pin if we have time, I'd love to come back to it. But I think, you know, Dr. Hendricks-Stirrup had a really great point about EMRs and standards, and maybe there's things we can affect there with, you know, I think the major vendors that, you know, create these systems. But certainly I'll share first, you know, locally what we're doing is now kind of, I mentioned earlier, you know, we thought we're doing a great job collecting race and ethnicity data, you know, because we've got, you know, completed 98% of the time, and the, you know, 1 or 2% of the time we think is probably all these new patients that, you know, just haven't come through fully registered and whatnot. But what we're realizing now is what's important is you need to take a good hard look at the data itself, and what are the things you're actually recording in there. And I think when we're peeling back the onion and looking at that, and especially, you know, with a more scrutinizing eye, especially for our, you know, we've got 7 hospital campuses in our health system, but realizing that, you know, gosh, you know, some of our health, you know, hospitals are in, you know, more diverse areas. We've got a lot of patients who are recording, you know, either patient refused or other or unknown as they're in the race ethnicity field. And why is that? And I think if we go back and look and we kind of realize, you know, a large reason may be, in fact, we weren't offering them all the granular choices that they needed, either that they didn't identify with any of the race choices we gave them, or perhaps they, you know, are multiracial or multi-ethnic, and we don't make it easy to do that, or we haven't trained our staff to ask in a sensitive way, or maybe the staff don't know how to record that. So there's a lot to do with, I think, system configuration, as well as training front desk staff, as well as even education of our clinicians and our patients. A ton of work, I think, in that area to really get to where this information is as accurate and granular as we would like to have it. You know, to your question, Carla, too, also, you know, about standards is also looking at standards, and for us, you know, adopting and looking at the OMB standards and how we can, you know, have those granular choices, you know, for the patients without overwhelming them with too many choices. And then how do we map that back into, you know, subcategories that we actually can then use for research. so that because you have to do some grouping to be able to do analyses and things and have the power that you need for for research, and that there's a challenge and a delicate balance, I think there. And part of that too, I think, is the importance of working, having leaders now in diversity, equity, and inclusion who can help us navigate that, especially those who are physician, have a research hat, like Dr. Nunez Smith, so that we can actually do that in a very thoughtful way, present patients with the choices that they want and need and deserve, but then able to use them in a meaningful way in research and for population health and other things. It's very, very tricky, and I think that's where too, kind of circle back to what Dr. Hendricks Stirrup's comment about EMR standards and things. It may be something that really hospitals can't individually do all on their own. Maybe it's us working with the vendors, and there are smaller number of major vendors now, for especially in big hospital system EMRs. But I think helping them to educate them and helping them to kind of build systems so that out of the box they're pretty useful and don't have to have that much customization, but have a lot of the standards for race and ethnicity that we need, and be able and maybe help us with the mapping so each hospital doesn't have to do it by themselves. And then lastly, I think one other way that we can kind of try to tackle these problems is also to work with our community. And we have a great program that with our what we call the Culture Ambassadors program, where we work with our minority community leaders. Many of them have been educated about clinical research. They've done dozens, if not hundreds, of hours of education to be representatives for their community. But I think opportunities for us to also work with them to get their feedback on how do we delicately capture information. And then we're even exploring pilot programs with them. Potentially, can they help us record some of the sensitive information, because patients may feel more comfortable opening up to community member or community leader rather than a nurse or a doctor or front office staff that they've met for the first time. And so I think there's lots of opportunities there. But there's so much of both what Linnell and Dr. Hendricks Stirrup mentioned just today just resonates so much with the work we're doing and trying to tackle here locally.
Well, thank you for that. I mean, I heard ambassadors, from your clinician ambassadors or your clinical ambassadors to your community ambassadors, helping tackle these tough problems. But as we're going to talk about later on, there are solutions. You've been part of creating them. Others have created them, and we're going to review those. So I want to thank you all for this wonderful conversation, and I'm going to pass it back to Susan.
Excellent. Well, I think everyone should join me in thanking our discussants from panel 1. It was just great to hear each of your perspectives. And now we're going to turn to panel 2. And so in particular here, I would invite my colleagues to turn on their camera and get ready to engage. We're going to hear from Luis Cabanilla, who's Director of Clinical Analytics at Point 32 Health, providing us that payer and population health perspective. From Dr. Bradley Mallon, Accenture Professor at Vanderbilt University, with that data privacy and security lens, and Dr. Crystal Sosi, Indigenous geneticist, bioethicist, and Assistant Professor at Arizona State University, for the community engagement and bioethics perspective. So our second panel, thank you so much for joining us, and we get to build on the rich conversation that we just heard. I want to turn first, Dr. Sosi, to you. And one of the things that we heard throughout the conversations and was underscored today, a commonly recognized barrier is that people in communities don't have a relationship with the systems collecting these data. In fact, that was just mentioned in the last answer from our last panel. And that isn't surprising, and you flagged in workshop 9, and in fact, I want us to pull up, I think we have the slide from the workshop where you presented, that the data from Indigenous people, from people of color, goes to the benefit of others and not to the communities from whom the information is being extracted, which would seem to just exacerbate the problem that we've flagged here. So, Dr. Sosi, how do we address that? How do we protect against it? And is there a part of the roadmap that gets us closer to community-driven data governance?
Thank you so much for the invite, Akihet. I'm going to first start actually with some comments about step one of the roadmap, because I think if we get that first step wrong, we're absolutely going to derail the other intended steps. And part of what I'd like to shift the conversation to is actually just a fundamental acknowledgement that we all need to collectively come to realization that there is a role of incentivization here that is perhaps misapplied on the path to health equity, that aligning research with market forces is not going to bring about health equity because the market itself is inequitable. And ignoring this will mean that change will never happen in a way that truly is equitable in the way that we're intending these conversations to move forward. We don't operate in a free market space and may possibly never. For many or most applications of biomedicine, operating in a free market space is inoperable because there are safety and efficacy concerns for patient and participant safety, which is why governmental agencies like the FDA exist in the first place. But the other extreme doesn't exactly work either. We are seeing that we have very few entities that have large enough market forces and power to both equitably benefit from public open data and also federal dollars, but also use that same market power to outmaneuver and outpace smaller or non-conglomerate or emerging tech companies within their own fields. Or when we're talking about this type of inequity across entity type, we see the use of that market power misapplied to outmaneuver or outpay academic or other entities for the right to claim intellectual property. So Operation Warp Speed in response to SARS-CoV-2 is an excellent example of this first point. The antigen was the part of that vaccine that was most novel. The actual mRNA vaccine delivery technology was actually based on rather staid and established technology over years of research or decades of research. It was really interesting that we see this huge giant ramp up utilizing public funds that then resulted in the centralization of a duopoly who then turned around and used and quite effectively benefited from that research and then shifted to our market model for the further dissemination of the vaccines, right? And of course, there's a part here to be stated about the role in which the use of the of wanting to include inclusion of minoritized or indigenous peoples in this had an actually like PR press releases by one of these companies and its effect on that company's relationship on communities and whether or not the collection of biological material may be actually superseding some of the moratoria that some tribal nations have in place and some of the maneuvering in terms to try to respect tribal sovereignty in name, but then in practice go around it. Doudna versus Zhang is actually one that also demonstrates the point about sometimes entities can fast track their claims to intellectual property and that can disenfranchise academic institutions. But we also have to understand that academic institutions can utilize the, by Bayh-Dole Act to substantiate their claim over IP from research that's federally funded as well. So it's unsurprising that both have large legal teams. And Doudna versus Zhang was an example in which one was able to just, put a little bit more money into the system to maybe fast track it. And I understand this is a small piece of a very complex case, but I do want to state that this type of IP system does disenfranchise communities and local partners. And not even in the IP space, but rather in just data sharing and use agreements, memoranda of agreements, and contract languages that are already template languages for universities when they're used to try to engage in community partnered research. Communities, if they don't understand that legalese and understand their actual real rights and how reduced they are, may actually further be disenfranchised. And we have to understand that we have to increase equity in those spaces as well. I really do want to state that this does lead to the overpromise that Indigenous peoples and other people are told, it's effectively our fault that if we don't engage in genomics and precision medicine research, then we're never going to benefit from that research. That's victim blaming, that is coercive, but also it doesn't really respond to the fact that we're not getting access to the essential things for preventative health anyway, and overpromising this on things that researchers cannot deliver on is going to conflate people's expectations of the research, and when they are not delivered, also deteriorate trust even further for these communities. And I do want to highlight just in my last minute that point about tying innovation with market forces and IP is just wrong. Like this is something that even health economists recognize, that there's something fundamentally needs to be fixed when Indigenous peoples are told that because we constitute 3% of the general population, that is not profit generative to use our DNA to study conditions that primarily affect us. And that instead the interest is for us as rare variants or undiscovered variation to create drugs that affect non-Indigenous peoples. That is the absolute definition of extraction. And we have to make sure that we're not using these calls for increased inclusion of our peoples in studies without also increasing equity, that we're not just substantiating and facilitating that extraction.
Dr. Sosi, so powerful in reminding us that, as we talk through some of the very practical and somewhat sterile barrier facilitator and solution, that this work really requires, to paraphrase you, respecting not only in name but in practice, and to have actual engagement and understanding, not just kind of yielding the result of where you get participation, but you haven't really engaged and worked with the community. And I think noting on that, that the approach of blaming or shaming doesn't really get us to a better place if it gets us a few more data elements that then don't actually help us do better in correcting historical and current inequities and discrimination. So really appreciate you giving voice to that and reminding us that as we look for solutions here, that idea of being collaborative and having actual engagement is really essential. So thank you for that. And I should say to all three of you, feel free to jump in and contribute to the conversation here. This is really about the four of us having a dialogue, so that those the folks who are listening and thinking through those barrier facilitator solution approaches can benefit from your thoughts. So I'm going to turn, well, Louis, you're up next. I'm going to turn to you, and you participated in our last workshop, and you said there, oftentimes the things that get incentivized aren't the things we say we want, which actually Crystal might have just helped us with, right? when we really want to address the inequities, but we're incentivizing some of the data collection. So she's helped line us up here. Tell us more about that kind of incentive mismatch, and do you see any of the solutions that Dr. Clary presented, those triads, as getting us closer to aligning the incentives and the stated goals?
Sure, and I will say thank you. I think that the speech before me covered a lot of what I would have wanted to get across just as a point. It was really interesting to hear, and it was really fantastic to be a part of the same panel. So thank you very much. I'll say a couple things. So again, if you're collecting the data, and what I worry about a lot, and then what I've seen a lot, you get to the first stage is that you're going to collect the data. So you have all this raw data. That's fantastic. REL will tend to be collected alongside SOGI data, SDOH, all these other things. So you know more and more about why certain populations are vulnerable. And what that means then needs to be interpreted the right way. So I think within this group here, everything seems everybody's great and everybody's like really motivated about this. I was just earlier this week at the Health Equity Compact in Boston, where it's like all these diverse leaders across the state of Massachusetts that are looking to do it, and it's great. If you're in that community, it's easy to kind of think that everybody has the same incentives, right, or understands the data the same way. So really the point that I was making, I think previously, what I've tried to make the point a few times across different venues is that REL data then gets used in different ways, and it's almost impossible to control the use. So if you're putting the REL data and you say, all right, we have REL data, we want to create an algorithm, so it's going to identify a member, or it's going to identify a likelihood to engage. It's looking at patterns, and so those patterns, it's going to pick up a pattern of systemic racism. It's going to pick up a pattern of marginalization. And it's going to continue that pattern because it's looking to optimize whatever you tell it to optimize. So if you say I want a likelihood to engage algorithm, you're going to say who traditionally has been the easiest to engage, and that what you're going to pick up are the members who have been most likely to engage with healthcare. And so the speaker just before me, exactly, it would say like, oh, this group of Indigenous people is very hard to work with and bother to call. But the algorithm isn't biased; it's doing exactly what it's told to do. But the construct that we gave it, the historical data that we gave it, and the guardrails that we put around it, put it in a position where it's just exacerbating a problem that's existed for generations. So it's important to understand and put the right guardrails around what you're trying to do and conceptualize what the end goal and what your strategy is to really address or help the community. Beyond that, I mean, there's a lot of financial considerations. So with a risk adjustment, there was just a study that came out earlier this week from Avalier that said that within the Medicare Advantage groups, people of color tend to be higher cost than the risk would assume, and white members tend to be cheaper. So if you're purely profit driven, which is a fairly significant percentage of healthcare is, then the message that you hear, what you pick up is like, I'm not being fairly reimbursed to work with minority groups, so I'm going to try to work less with minority groups and more with the white groups, or easier to engage groups that are paid at a more fair rate. So it's not trying to draw any negatives or be like super positive, but it's just being realistic that there's cost considerations, especially at this point in healthcare, that a lot of groups are just trying to figure things out and then have different profit motives than they've traditionally had in the past.
So does the one of the things we've talked about in the RAISE workshops was part of the transition to more of a kind of a value-based or a risk-based payment. Does that help us with some of that transition, where it's if you were responsible for a population and their healthcare costs, and therefore you want to invest in more of that kind of prevention and proactive service, might that help us, or is it well, I'm going to perhaps answer my question as I turn it to you, or is it another place where it might, but we have to be careful and make sure we are actually incentivizing what we want to see be pulled through?
Yeah, I think it's certainly well intentioned. It's the same thing. It could go really well, or it could go very poorly, depending on how it's created. If you're looking at a quality score and say we're going to value based on a HEDIS score or something like that, which we talked about in the previous session, you're looking at a point in time. So you're looking at when there's a member that comes in that you collect the race data, what's their blood pressure, what's their hypertension, if it's cholesterol, if it's what the preventative screening is that you're working on. But you have to follow the entire life cycle of a member. So there's an aspect of, are you cherry picking members where you're only trying to get certain communities to work with, and you, as a result, have a very easy group of members that you're working with? Are you encouraging members implicitly or explicitly to disenroll from your plan? And so like you have to first put in the guardrail, which is like, I'm getting members that are representative of the community that we work in. And second, that I'm keeping those members and those members are engaged. There's the quality aspect in terms of what their experience is with the plan, what their experience as a provider. And then I think it's fine. Then you can have like those quality measures, but constructed in a way where it's like a focus on identifying areas of need and addressing areas of need versus just having like putting a blanket over all the boxes and saying this is the shape of what it looks like. So you want to incentivize improvement versus incentivizing necessarily like a specific outcome at a point in time.
Got it. Got it. Well, one more piece, and then Dr. Mallon, I'm coming to you. So, Louis, is there something you've learned in your company, Equitable Analytics, that helps clients meet health equity goals? Or is there a particular component there that has been most valuable if you are trying to achieve the health equity goals? Is it getting that data right, or getting the interpretation and use of the data right?
I think the thing that I've learned is like it's great. Everybody is interested and motivated about doing something, but everybody's intimidated about where to start, and they kind of feel overwhelmed by the size of the problem. So the biggest learning is just having a clear strategy for what you can do. What's the most easy point that you can start at where you can have some wins? Using census data is a fantastic way to start, where you can supplement a lot of the data gaps that you have. I think a lot of what we've talked today, there's barriers and gaps, and really having a coherent strategy around collecting REL is probably years down the road, but there's work that you can do right now to start that journey and start having an impact in your community. But you need that data, and you need to create it in a way that you can measure where the populations of need are and what the impact is that you're having on those populations of need, in a way that's kind of commensurate with what your technical experience is, what your resources are, and what your real goals and values are as an organization.
Okay, super helpful. And then remind me, REAL data, race, ethnicity, and language?
Correct, yes.
All right, good. Just wanted to make sure I was straight there. So Dr. Mallon, actually, Louis just raised it, and it came up in another of our workshops that part of the problem here is if you have more data about people of certain races who are more likely to report their data, then that influences where resources are directed. And then because the care management tools and the artificial intelligence is overwhelmingly populated by those races, then we start predicting need for the recognized communities and just continue to not hear and recognize, and it drives that lack of recognition for unrepresented communities. So it would seem that there's a need to report the underlying training data that the algorithms are operating on, and a need to improve the data collection, another need to improve the data collection for the subpopulations. But in the meantime, how do we build models to identify the potential bias?
And we want to go with easy questions today.
Yeah, exactly.
There are a lot of, so you can think of this in a technical sense, and you can think of it in a socio-technical sense. First, I want to point out that I personally have a bit of a worry in a focus on, in an over-focus on the notion of bias and algorithmic decision making. Okay. Not because it shouldn't be addressed, but I worry that the statistical and the computer science community has become enamored with this as a way of trying to address problems. In that there's this belief that if you can just figure out how to debias the algorithm, then you're gonna be able to solve the problem for everybody, and that's not really the case at all. You were starting to address this issue by saying, could we put some type of a warranty associated with the algorithm itself, or whatever technology was built, by saying this is the training data that was used. But it could give you a little bit of a leg up in trying to understand what the decision-making algorithm is based upon, but it still doesn't get to the heart of the matter that not all data is built the same. And so even if you say we built this algorithm on an extremely diverse population and it has equal representation from every race and ethnicity that we want to represent, that the algorithm is only going to be telling the truth at this point. It's like that makes a lot of really strong assumptions, right? It assumes that the information that you collected from each of the populations was equally represented itself. So like if you have missing information from certain things simply because certain subpopulations don't feel comfortable with the people who are collecting the data in the first place, where you end up with some type of evasive maneuvering with respect to saying, like, I'm not going to tell you this because I don't trust you, then that really puts you at a disservice. You can't really say that the resulting algorithm is unbiased simply because the algorithm has been debiased. The data itself is problematic, and the collection of the data was problematic. And I think one of the reasons why you end up in that situation, where there are many reasons, but one of the important ones is the fact that there's not usually a good indication from the outset of why the data is going to be collected in the first place. And so if that's not clearly communicated, then it becomes very challenging to establish any type of a rapport with the population that you're trying to help out, or all the populations that you're trying to help out. Instead, what you end up with is a situation in which groups that have been discriminated against in the past just go, I'm not giving you this data. I'm not, you have not helped me in the past. You have no intention probably of helping me in the future. So go find somebody else who's going to provide you with this information. It's not going to be me. So I look at this as, there is certainly an algorithmic component that needs to be addressed, but I think that there is just a human element that is probably, in my opinion, much more important to address, but much more challenging to address. And so a lot of organizations are going to have to acknowledge that you have to build up the relationship in order to achieve some type of a technology that eventually will be equitable. There's more to it than that, but you really have to get to that point first.
Yeah. So the perhaps then, right, important to understand the challenge in the algorithms and the algorithmic bias, but then we have to get back to how we do a better job in collecting the data, is establishing those relationships and being committed to communicating about how the information, what the information would be used for, and then using it in a productive, in a way that is helpful to those from whom you are gathering something.
Certainly, and okay, so I'll hammer on this a little bit more, and then so that you then have to get an organization to commit to using the information that comes out of the algorithm or out of the predictive model to go back and try and influence the system. So it's not sufficient to say, well, we got the data, we've got a good relationship, we're now doing our predictions, and guess what? We're still predicting that the majority population is going to use this service that we're offering to them at a greater rate than another population or subpopulation. And so then you have to say, like, okay, well, yeah, that's the data. But now the question is, well, why is that the case? Right. And so that now you have to go back and say, like, okay, so your population is not benefiting from this in the same way that another group is. Are we doing the wrong thing? Right. So like, yeah, it's a question for reflection, not just to say, is the algorithm performing well? So I see this as like, it's a tool, it's a mechanism that can be applied, but it has to be embedded within the larger ecology of what you're trying to solve.
Really helpful kind of illustration, and then driving us back to that sense, the imperative to have the better conversations and to try and change what's happening there. I want to come back, Dr. Tsosie, to you and hear a little bit more. Are there illustrate? Could you invest a couple of minutes and illustrate for us, like, what does good look like? What does good look like in the efforts here to have the conversations and actually engage and work with and solve some of this the mistrust that we've earned and yielded?
Sure. Like, if we really want to practice what we're preaching, that we want to use data to increase health equity, then we should also be paying equal attention to ensuring that Indigenous peoples and local communities can also be the data collectors, create companies based on their own data, and similarly claim IP and create innovations based off of their own data, and then honestly, we wouldn't need to have as many outsider generated data standards, respectfully including the roadmap, because we would be doing it ourselves. And I think that's the difference between community-based or community engaged or community partnered research. And then that's when we start moving towards tribally directed research. And that's the future that many Indigenous peoples envision for themselves. And the cool thing is, the amazing thing is that we can already do this. Like we're already doing this with blockchaining and federated learning. But these types of tools absolutely requires also Indigenous data repositories and on Indigenous servers subject to Indigenous community regulations. And we're able to do this, like for instance, at the Native Biodata Consortium, which is a nonprofit Indigenous research organization that is housed on tribal lands. And we, because of this, that we're creating, like we are also encountering questions like how to govern our data, how to manage data sharing rules, guest to data sharing rules, and be accountable to our community members. And we just by nature of needing to expand on our data governance and our platforms, we were able to advance on a dynamic consent platform and an model. And we're basically advancing on old models that presumes that we require open everything, that everything needs to be downloaded to local machines. This is like a problem that we see in international consortia, like the Human Pangenome Reference Consortium, and it presumes that it requires this old pathway, this old pipeline of analyses, when in reality, like we've already advanced upon that. We are already doing this in other domains. And we just need to more widely call on utilizing and including those tools in these other types of projects. The problem is that this is sometimes, like, depending on who you are, like what type of entity you represent, this could be unsettling and disruptive. But also we need to recognize that some of those people already inequitably benefit. So they can't also be the ones calling on the rules and creating the rules and then calling it equity because oh gosh, we just have to recognize that we also operate within the conflicts of interest as well. But if we can move beyond like understanding and really analyze the types of administrative practices that we think are state and start thinking about opportunities to change the system to create inroads for innovation equity and data equity, then that's, I think, how we are ultimately sustainably going to impact health equity as well.
So it's then, as you noted, the tribal driven and really rethinking not only how things are done, but who is doing them and under what kind of rules and structures.
Yeah, so I'll just give you one example. I work with a tribal nation that's rather small that doesn't have its own, well, it has its own IRB. And the NIH via Common Rule and other entities, doesn't really matter about the NIH, but in this example it's the NIH, but most federal agencies, they recognize tribal sovereignty in language, but they don't really spell out all the threats that are already ongoing that threaten and disrespect tribal responsibility. So they created this single IRB mandate rule to streamline research, but without really giving some guidance on how academic institutions should also respect tribal sovereignty. So there's an example in which a community wants to work with a larger R1 institution, and their institution just has an institutional policy to refuse to cede control to an external IRB, including tribes. And that type of friction is pervasive in MOAs and DOAs and contract languages and IP, and it's stalling research. And the lack of actual, even though there are agencies that fund or try to increase calls for community partnered research, it still presumes or requires an academic lead, or because they have the administrative capacity to do that. So there are inroads that I'm seeing changed. There is more that can be done, and not just in all federal agencies, but also in how we, as like, for instance, in IPO offices and intellectual property offices, how those rules are created. And we just have to start thinking about where are these structures actually in processes, where are they just privileging one entity type versus another?
And exposing that, and then saying, how do we correct for that? Louis, I saw you had your hands up, so I'm going to let you have the last word, unless Brad wants to jump in here, because then we've got to turn it back. So Louis, go ahead.
I'll speak super quickly. I just again say how much I enjoy this panel. But the point about it being like, ultimately, these are a lot of community-based organizations that A, are the best generators for data, but then B, also the best solution for the data, for what you're going to do with the data. And so there's so much, I think, where a health insurer can fit into it, or even a provider group. It's helping to draw those connections. And I think that point was made in the previous panel as well. There's resources out there. There's groups that want to be involved in the community, formalizing a funding structure where groups are appropriately funded. And it's really at a community level, not like necessarily huge national organization or anything that's super fancy, but it's something that's going to really address a need in a neighborhood or in a few neighborhoods within a city. That's ultimately, I think, going to have the biggest impact.
Yeah, that this is not a widely distributed e-questionnaire that somehow solves a difficult problem. This is communities working together to address it. Brad, you get the last word.
Okay, so I'm going to echo what Crystal said, because I think it's really critical, but rephrase it slightly. So the notion of sovereignty is really important to recognize. It actually flies in the face, however, of the way that the scientific community has headed probably over the last, I would say, decade, and if not a little longer. And it's been, this push towards open data and open everything. It flies in the face of sovereignty. The goal is to support reproducibility of studies, but at the same time, it implies that everybody wants to have data out there accessible to anyone at any particular moment for anything. And that I really think that that's a problem. Speaking as somebody who's built platforms for sharing data and analyzing data, this notion of give me the data all the time, it is really, in my opinion, it works in some situations, but I don't think it really addresses the ways in which certain populations and just certain people in general want to have different types of control. It really forces us into a situation where, for some people, it leads to lack of trust again.
And so perhaps you're flagging for us, then one of the solution opportunities here may even be to rethink and say, how might we do, how do we do that presumption of open access? Let's relook at that.
It's just how do you think about governance structures?
Yeah.
And I think that the governance structures have swung in a certain direction that suggests that the producers of that information really have no rights to the control over it and its use. And that's where we are today, which has put us into a bit of a conflict.
Yeah. So giving us something really, really, I was going to say meaty to chew on, but to think through and say, how might we pursue that? Thank you so much, Dr. Mallon, Dr. Sosi, to Dr. Cabanilla. You knew I was going to call you a doctor again. So thank you so much for joining us for that conversation. We're gonna step away and let Dr. Rodriguez-Watson step up and talk to us about key takeaways and where we're going next.
Thank you. Wow, what a great conversation. I'm just going to take control of the slides. And while I do, I just want to, Brad, that last note you said makes me think of an old song. You want to make trade free and not fair. And what you're saying is we're making data free and not fair. So I think we got to get back to it. And I think this all comes back to where we started on workshop 1, trust. How do you get it and how do you keep it? So with that, I'm going to see if I can advance this slide. So I just want to say thank you again to Susan and to everyone that's invested their time with us here today. We started RAISE because we had this idea that missing data in real world data sets wasn't only because people opted not to answer the question. It was that the question wasn't being asked the right way. It was also that the answer choices, as you heard, a lot of times don't resonate and are not standardized, which doesn't allow for data to flow, which is needed in a healthcare system that is fragmented by design. And patients and communities have a significant level of distrust and in why data are being collected and how it will be used. But we also knew that there were many solutions out there. So the first aim of RAISE was to gather them in this forum over the last 10 workshops. And I'd like to say that everyone, or ask everyone, how do you think we did? Since you're all on mute, I'll just imagine that there are tons of applause. Now, we're happy to say that and share that we had over 500 people registered for the series, plus an additional 200 or so, I think, registered today. And we truly want to thank you for making the time on your calendar to spend 1 hour twice a month with us. And based on the approximately 300 people who were presented with the registration questionnaire, this is our distribution by race and ethnicity. It's a great response rate with only 4% non-response. And compared to the 2020 census, people of color are slightly better represented in race at 42%. And for those of you who identify as Hispanic or Latino, you were underrepresented with only 7%. And if we go by stakeholder group, we could see that representation of 13% preferred not to answer, or maybe we didn't see themselves in the categories that we presented. 23% are from healthcare, and that includes care delivery and payers. So that's great, as those are kind of our target sectors for real world data. And 19% are coming from life sciences and tech, which is super, as they support our target audience with the products to care for people and the tech to hopefully make the RAISE wish list a reality. We had healthy attendance for research at 31%. So that's great. And so hopefully you got some insights that will make you consider the variables that you're getting, whether you are stating clearly why you're asking them and whether you could use these data in your model, and because they align. And so now we're going to jump to it. Over the course of the RAISE series, we have summarized our learnings in this phrase, or call to action: rise up. And we're going to go through each of these letters. So R, I'm going to sound like Sesame Street here. R is for respect for community autonomy, acknowledgement of structural inequity, and cultural humility to facilitate a better understanding of the importance of partnership between systems and people, particularly for community-driven data governance, benefit risk sharing, and alignment between the goals of the systems and the people. Partnership needs to be consistent, as the Institute for eHealth Equity showed us through their base within local ministry. This location facilitates important communication, consistent communication, to understand community and health needs that inform relevant programs and opportunities to engage in research that is bidirectional. Partnership also means coming with the tools and tech that enable communities to engage with their healthcare and drive their healthcare experience, as shared with us by Sky Health. For more information, you can go to the summaries for the workshops noted in the bottom left-hand corner of this deck. Community partnership is really critical as it helps inform appropriate standards. We talked a lot about standards. People generally don't describe themselves in terms of the 5 OMB categories and can't conceive that Hispanic or non-Hispanic are the only ethnicities in the world. This makes it difficult to answer the question, with what race do you identify? And in terms of alignment, if people aren't clear in why they are being asked their race, as Dr. Mallon just said, then their answers will be equally unclear or missing, which leads to problems with interpretation and aligning community with health system goals for the health equity, because you can't describe the community properly. As we heard in workshop 5, the effort to work with the Arab Community Center for Economic and Social Services, or Access, had an impact beyond simply securing a new category for a federal survey. It resulted in a community feeling seen and included. And the proof of impact is right here. If you go to their website, you see they are pushing participation in research and reporting of race. Okay, I is for intentionality and transparency in collecting race and ethnicity data that can help address mistrust, misinterpretation, misclassification, and missingness. A recent systematic review in the American Journal of Epidemiology on the utilization of race and ethnicity in major epi journals found that in only about 1% of studies collecting race and ethnicity were the terms specifically defined. And that's similar to what we heard here from our two panels and from maybe your own experience. When you went to the clinic last time to see your care team, did anyone ask you your race and ethnicity, much less tell you why they were collecting race and ethnicity and how it would be used? I don't hear it. Systems need to be consistently clear on why race and ethnicity is being collected, otherwise distrust festers. From our own COVID-19 vaccine confidence project, one important quote from a consumer listening session was, "The more they study me, the more they know how to get rid of me." And when there is distrust, there is no reporting or there is underreporting, which leads to missing data and measurement error as described in Beyond the Boxes. And this missingness impacts descriptive studies. From workshop 1, Dr. Georges Benjamin pointed out that just looking across the US population, we experienced over 1,100 excess deaths in 2020. But there was huge disparities when we look across racial strata. And this missingness also has impacts on prediction models. As I described in workshop 1, the estimated glomerular filtration rate is a measure of kidney function commonly used in clinical practice. The higher the number, the better the kidney function. The two most common equations for estimating this equation were based on populations that were more than 80% white. This has led to delays in recognizing kidney disease in Black patients until they are well into stage 4 or kidney failure. This delays registration in transplant lists and increases the risk of death for these patients. Another example of prediction bias comes from workshop 7 in the work of Fawzi, who identified that the pulse oximeter overestimated blood oxygen in all non-white populations, which led to failure or delayed COVID-19 treatment. So I say we should just all say no to algorithmic bias. Misclassification can also impact inferential analysis. In workshop 8, Tegan Bremer from CDC shared the study of COVID-19 treatment with Paxlovid. The percent treated is lower among the white race when it includes Hispanic ethnicity, as you can see on the left panel at 13.5%. Then when Hispanic ethnicity is excluded, on the right you see 14.3%. This results in different magnitudes of disparity for both relative and absolute differences when comparing minority racial and ethnic groups like Black or Hispanic to the majority white group. All right, so our next letter here is S, standards. Standards that are needed should be safe, contextually relevant, and interoperable. Regarding safety, Dr. Brad Mallon, who you heard from earlier, showed us the trade-offs we need to consider between granularity of data represented by on the y-axis as utility and privacy. Contextual relevancy can be supported, as we heard earlier in the panel, by tools such as those from EHR vendors like Epic, which allow clients to turn on HHS code sets that are relevant to their populations, all of which can still map to the OMB categories. And interoperability for race, ethnicity, and variables representing social determinants of health can be made interoperable across systems using standard taxonomies and messaging standards developed by HHS and the Office of the National Coordinator through Project Gravity and USCDI, respectively. E is for education. Education is needed to increase awareness of incentives and resources for infrastructure, technical resources, and best practice. As we said already, there are many solutions out there. We just need to socialize them better. First, there are the resources and incentives that the value-based payment models, also known as accountable care models, have been rising, and commercial payers own the largest percentage of ACO contracts. As described in workshop 1, these models allow for infrastructure investments that support the health equity for both fee-for-service and bundled payment models. And technology such as tokenization, described in workshops 2 and 3, allows linkage of patients across multiple systems, protecting sensitive, identifiable information, has proposed frameworks for harmonizing sometimes conflicting race and ethnicity data over time. As Dr. Shao acknowledged, race and ethnicity could change over time, or as Dr. Hendrik Stirrup said, the migration of those data creates lots of problems that may default to inappropriate defaults. And finally, workforce training modules. There it goes. Like the ones described by Massachusetts General and the Veterans Administration that help us understand gaps in workflow and training to help staff appreciate how to capture race and ethnicity data sensitively and help us understand health equity, and for staff to inform how to best collect the information within the daily workflow. U is for understanding and alignment to address the dissonance between why race and ethnicity are collected, how race and ethnicity questions are answered, and how race and ethnicity data are used, and how communities versus health systems define health equity. So that lived experience versus the system metrics. We want to be able to bridge that gap. P is for payers. Payers can collect race and ethnicity data too. And there are actually only 5 states where race and ethnicity cannot be collected, and that's only at enrollment, as we discussed. And 2 of those states have exceptions for the purposes of measuring quality of care outcomes and performance measurement access or hospital insurance collecting demographic data. So that's it. This is our call to action. Rise up. Press your leadership to take advantage of value-based payment models and pay for equity, to invest in changes we talked about and align with NCQA and JACO requirements. And if you're already doing it or doing some of it, share your learnings with others and be humble and accept help from others and from the community. We hope this has been a forum through the summaries and its hot takes from the chat to identify colleagues who can further your work. So while this workshop series has concluded, we'll be busy behind the scenes refining the barrier solution facilitators roadmap, conducting our evaluation of the RAISE program. We at the FDA Foundation are committed to furthering this journey, and the Office of Minority Health and Health Equity, I'm glad to say, is committed to continuing this journey with us. We do plan to reach back out to organize work groups, and we hope you'll answer the call. And with that, I want to give a huge and hearty thank you to all the speakers and the workshop champions that have helped us organize this wonderful series. And of course, to the team whose dedication and commitment just floors me. So that's all I have. Back to you, Susan.
Carla, thanks so much for taking us through that. Thanks to all of our presenters who've been participating, and thanks so much to each of you who have joined us for today. That concludes our meeting. We look forward to working with you and making appreciable progress here where we actually engage and work with the communities to, we know we can do better in the health equity space, and that we can do better in our collection of race and ethnicity data. Take care, and we'll see you soon.